Now, Leukemia Committee Chair Dr. Harry Erba, with or without his sandwich, will be telling us about his committee's work. No sandwich?
I didn't get to the sandwich yet. If Ann Schott's out there, she's probably wondering what I'm doing wearing a pink shirt and pink tie instead of my usual white and red. It's because I thought this was another Baker challenge where the leukemia guy had to talk about the breast cancer studies, but I got it wrong. Instead, I'll tell you what I'm proud of in the Leukemia Committee. And I'm going to start, as a hematologist would start, by showing you a slide of bone marrow and peripheral blood cells from a patient with myelodysplastic syndrome. This is a bone marrow failure syndrome characterized by dysmorphic maturation and a number of genetic defects that have been discovered with a tendency to progress towards acute myeloid leukemia. This is a disease of advancing age, and so the only known curative option, being allogeneic stem cell transplant, only applies to a minority of our patients that we're seeing in our clinics. And patients with higher risk disease, intermediate 2 or high risk disease, have median survivals of only about a year, and you can see most of those patients in the blue and purple curves have passed away within 5 years. So a very poor prognosis, and this risk score comes from the number of blasts in the marrow, the number and degree of cytopenias, and cytogenetic analysis. There are a couple of FDA-approved drugs for this population of patients. I'm showing you one of the hypomethylating agents, azacitidine, the other drug, decitabine, have been shown to lead to hematologic responses in this group of patients. This is a study that was published in Lancet Oncology comparing azacitidine to either supportive care, low-dose Ara-C, or standard AML induction chemotherapy, showing an improvement in overall survival, making azacitidine a standard of care in this population of patients. However, these patients do not enjoy continued response, and you can see there's no plateau on this curve, and we know that for patients with higher risk MDS who ultimately have failure or their disease relapses after azacitidine or decitabine, the median survival is somewhere around 5 or 6 months. And so there's a real need to do something better. One of our SWOG investigators, very active in this area, Mikhail Sekaris at the Cleveland Clinic, in collaboration with colleagues at Moffitt and other places, did a phase 1 and then a phase 2 study of azacitidine in combination with an IMiD, lenalidomide, in higher risk patients with MDS. And what he showed was a 72% response rate, and they were very impressed by the median CR duration of 17 months and counting, and a median survival, overall survival of 13.6 months, not quite as good as in the AZA-001 study. Our colleagues, one of our colleagues from the Alliance, Lou Silverman, who actually has the credit for being the PI on the CLGB study that led to FDA approval of azacitidine, did phase 1 and phase 2 studies of azacitidine and Vorinostat, a histone deacetylase inhibitor, in various doses and schedules, and basically decided that this cohort 2, with a very low number of patients who were given the standard dose of azacitidine in combination with the HDAC inhibitor Vorinostat, had a similar high overall response rate, similar to what was reported with azacitidine and lenalidomide, but again, the median duration of response seemed longer than expected, and the median survival, 37 months. So these phase 1 and phase 2 experiences by Alliance and SWOG investigators led to an intergroup concept, testing whether either of these regimens might be better than the standard of care azacitidine in patients with higher risk myelodysplastic syndrome. So an intergroup concept and protocol, 240 patients. The primary objective of the study, however, was only to look to see if the response rates would be improved by the addition of an IMiD or an HDAC inhibitor for a variety of reasons. Overall survival was a secondary objective. Activation was in March of 2012. Well, based on our prior experience with ECOG 1905, we expected 6.5 patients per month and an anticipated accrual time of 2.5 years. But actually in the last year, we have accrued 16.5 patients per month with general agreement between all of the cooperative groups to place patients on this study. And in fact, as the study was coming to a close, we still had other sites trying to enter the study. As we are thinking of where to go next in myelodysplastic syndrome, the unfortunate reality is that there are no other drugs that are ready to bring forward, and more importantly than which drug, there's really no understanding of which pathways to target. Lots of mutations have been discovered, but we still are not certain which targets we should take advantage of. And so the cooperative groups got together and thought, wouldn't it be nice to actually try to change the standard of care for these patients and turn this into a survival study? So what we did was we temporarily closed the study on April 15th when it met its accrual of 240 patients. And we've been in discussions now with CTEP and our industry colleagues at Celgene and Merck to increase the sample size to ask a question whether either one of these regimens might actually improve the overall survival of patients with myelodysplastic syndrome, and we're still waiting to hear about that. I'm not going to show you everything that we're doing in leukemia. I want to focus on the myeloid leukemias, and now I'm going to turn my attention to acute myeloid leukemia. The NCI Steering Committee pulled together a group of investigators to come up with ideas of how to improve outcomes for younger patients with AML. A number of things have already been done, like tweaking the dose of anthracycline or cytarabine, adding in other chemotherapy agents like MDR modulators, which we've been very active in SWOG, and frankly, that experimental design has led to no fruit, as I'll say. Targeting surface antigen on the blast, and I'll come back to that with our experience with gemtuzumab ozogamicin, and then looking at novel agents, novel cytotoxic or epigenetic therapies. We could also try to target the driver mutations in AML, the few that we have identified, and hopefully come up with better post-remission strategies through MRD assessment. We can try to improve outcomes of our patients with allogeneic stem cell transplant, either getting more patients to transplant who need it or improving their outcomes after that. So let's talk about our prior experience with gemtuzumab ozogamicin. This is an antibody drug conjugate directed against CD33. It was approved in 2010 for the treatment of older patients who are not eligible for chemotherapy in relapse as a single agent with a 25 to 30% response rate. As part of a post-marketing commitment, Wyeth Pharmaceuticals partnered with SWOG and actually the Intergroup ultimately to design this study comparing 3 and 7 daunorubicin Ara-C to the daunorubicin Ara-C with gemtuzumab during induction, followed by consolidation with high-dose Ara-C, and then a maintenance question with gemtuzumab. Unfortunately, this study was closed at the second interim analysis for 2 reasons. It was found that CR rates were not different, but more importantly, there was no difference in relapse-free or overall survival at the second interim analysis. And in fact, the induction death rate was higher with the addition of gemtuzumab ozogamicin. However, there was a subset of patients, those with inversion 16 and 821 translocations, the CBF AMLs, who seemed to do better, even though the CR rates down here in small print were no different between the 2 arms. The relapse-free survival was improved with a p-value of 0.04, and there was a trend to an improvement in survival. The interesting thing about this observation is it had been seen in other randomized trials done with gemtuzumab. So based really on the hard work of our statistical center, and specifically Megan Othis working with Eli Esty and Fred Applebaum in Seattle, we were part of a individual patient meta-analysis looking at the 5 studies that looked at the value of gemtuzumab. Here are the 5 studies: a French study that showed a benefit in a subpopulation of patients treated with fractionated gemtuzumab, a couple of MRC studies, and one from Europe, another one from Europe as well. And what was presented at ASH this year in this individual patient meta-analysis is that there does appear to be a clear benefit in terms of overall survival for patients with inversion 16 and 821 AML, accounting for about 20% of our adult patients, and a marginal benefit even for intermediate risk karyotype. So one of the things that we have been doing quite well in our group is using our data and sharing it with other groups around the world to add value to that. So in 2010, the NCI Steering Committee got together the AML Working Group to come up with the next set of studies that would be done. And what was decided at this working group that was held in Bethesda is that if we could target driver mutations, we should. And there were 2 driver mutations that we were interested in. c-KIT mutations have been shown to be involved or found in AMLs with CBF translocations, coordinate binding factor translocations, and associated with a worse prognosis. The Alliance was given the task of designing a study looking at the addition of a c-KIT inhibitor, dasatinib, to chemotherapy, and they have recently reported their phase 2 data. ECOG was given the challenge of developing the next study looking at a FLT3 inhibitor for patients, younger patients with FLT3 activating mutations. SWOG was given the rest. And we decided to look at a couple of different things, novel induction regimens, and then we knew that an adverse karyotype in young AML patients was clearly associated with poor outcomes that may be overcome by getting these patients to allotransplant. And so what we did was conduct a series of teleconferences among investigators from around the country, vetting a variety of different novel agents used in the Alliance and ECOG and SWOG at single cancer centers. And basically, after a statistical analysis of all of these different regimens, and we screened about 10 different data sets, it was decided that the regimen that might have the most promise for improving outcomes of young patients with AML is to combine an HDAC inhibitor with chemotherapy. And this was based on work by Guillermo Garcia Manero at MD Anderson. He was able to show in phase 1 studies that the HDAC inhibitor Vorinostat could change histone acetylation in patient samples. And so he did a study combining Vorinostat, this HDAC inhibitor that had activity in their phase 1 study in AML, with a topo-2 inhibitor, idarubicin, and high-dose Ara-C. And here's the regimen for your reference. But basically showed that responses were seen, and the responses seen compared to their historical controls of Ara-C seemed improved in all subsets. There was even a trend, not statistically significant, but a trend for improvements in response rates in patients with poor risk karyotypes of monosomy 5 and monosomy 7. And as I said, we wanted to test whether we could get more patients to allogeneic transplant if they had poor risk karyotypes, because these patients seemed to benefit from allogeneic transplant. And so 1203 was designed as an intergroup collaboration between Alliance, ECOG, SWOG, and the National Cancer Institute of Canada. And we are searching to see if we can improve the event-free survival of patients with young patients with AML by comparing 7 and 3 with idarubicin Ara-C or idarubicin Ara-C with Vorinostat. And also importantly, seeing if we can increase the number of patients who get to a transplant who need it, this poor risk group of patients in first remission. And we're doing this by having a collaboration with the National Marrow Donor Program, who will provide free of charge to subjects on this study who have high-risk disease, HLA typing, and the unrelated donor search. Here's the complicated schema. I'm going to finish with this. Currently, what we are doing is we are trying to identify driver mutations that we might be able to target that may lead to some improvement. But really, maybe what we should be focusing on is looking at why do some people with AML get cured? We clearly see them. There are patients who are clearly go into remission and enjoy long-term disease-free survival, and there are other patients who have refractory disease. And then the majority of patients have a response and ultimately relapse. Well, what we think we might be able to do is by comparing a variety of genetic assays between patients who are clearly refractory to chemotherapy, no response, and those who are in long-term remission, we might be able to identify some kind of signature that allows us to identify that group of patients who will benefit most from chemotherapy. And so this is called the Cardinal study, and that's because Tim Lay and Jerry Radish, who helped design the study, are big St. Louis Cardinal fans. And what they're doing is they're looking at the outliers, and we have data, we have samples from ECOG, Alliance, and SWOG. All of these samples have gone into the analysis. We are doing a variety of genetic analyses that I'll come to on the second to last slide. And basically, we're trying to find out if we can identify those patients who are chemotherapy sensitive and enjoy long-term outcomes, identify those patients who can go on to standard chemotherapy protocols, and those other patients who require something else. And then if we can identify pathways that we can target, more so the better, to turn non-responders into responders. This is a complicated diagram, but it just says that this work is well on its way. It was pitched to Dr. Varmus. It was approved by the NCI, and now we are here in the analysis. And what's nice about it is that each of the groups that are involved has the claim to some part of the genetic data, whether it be methylation through ECOG, microRNAs, CLGB, or Alliance, or the SNPs and RNA expression levels that Jerry Radich is doing. So what's our mission? Our mission is to improve the outcomes of people with leukemia. And I think we have to do this by showing that we clearly improve outcomes in a meaningful way, whether it's quality of life or survival, that clinical investigation needs to be driven by our best science, and that doesn't matter if it's SWOG, Alliance, ECOG, or anywhere else. We should incorporate, if possible, mentor junior investigators along the way. And the only way that I think we are going to survive as a cooperative group in these tough times is through collaboration, leadership in SWOG, and innovation, which I'm fortunate to have with my colleagues. I'd like to just acknowledge Fred Applebaum, who left me with a committee that was well-groomed to move forward in this genetic era, and I appreciate his help. He actually comes on the teleconferences every month and guides me along the way. Jerry Radich, our TM chair, Steve Coutre, my vice chair, Susan O'Brien, the executive committee, the executive officer, Megan Othis in our stats center, who is tireless, even with a new baby, and Sandy Fredette in our ops center. And then finally, our junior investigators and their mentors, Laura Michaelis at the Medical College in Wisconsin, working on older AML study that she's developing in the intergroup, and Susha Nand, her mentor, Michaela Liedtke, working in ALL at Stanford with Steve Coutre as her mentor, Kristen O'Dwyer, Rochester, also helping in ALL with her mentor, Dr. Avani, and Kathleen Phelan at Loyola, her mentor being Pat Stiff. Thank you. I apologize for going long, Dr. Blanke.